Ladies and gentlemen, welcome to this new webinar organized by the International Society of Gynecological Endocrinology and by the new journal, GRAM, Gynecological and Reproductive Endocrinology and Metabolism. We have today a webinar with a great speaker, I would say. We know her since a long time, and Professor Roberta Diaz. Our title is A Discussion on Precision Hormone Therapy Gaps and Opportunities. And she will be chaired by Professor Andrea Genazzani. So let me very quickly introduce you our panelists. Professor Genazzani is the president of the International Society of Gynecological Endocrinology. And since the 1980s, he's full professor of obstetrics and gynecology and has been nominated since then director of the Department of Obstetrics and Gynecology at the University of Cagliari, and then Modena, and finally Pisa in Italy. He is editor-in-chief of Gynecological and Reproductive Endocrinology and Metabolism, GRAM, and past editor-in-chief of Gynecological Endocrinology. Editor in Frontiers in Gynecological Endocrinology with Springer since 2014, and author of more of 850 papers in peer-reviewed journals, and editor of more than 45 books. Our panelist, Dr. Roberta Diaz Brinton, is Regents Professor and leads at the Center of Innovation in Brain Science at the University of Arizona, whose mission addresses neurodegenerative disease of aging, Alzheimer, multiple sclerosis, Parkinson, and ALS. Brinton is internationally recognized expert in Alzheimer with over 200 publications and is developing the first regenerative therapeutic for disease. She has earned her PhD as an NIH postdoctoral fellow at the University of Arizona and went on Rockefeller University as NIH postdoctoral fellow. Brinton is director of the Center for Innovation in Brain Science and professor of pharmacology, neuroscience, and neurology at the University of Arizona College of Medicine. She serves the National Institute of Health Directors Advisors Committee and the National Institute of Aging Scientific Advisor Committee and the Alzheimer Drug Discovery Foundation Board of Governors. Her research is funded by the National Institute of Health, the Alzheimer Drug Discovery Foundation, the Alzheimer's Association, and philanthropic contributors. Brinton's scientific research and STEM education endeavors have been recognized by numerous awards, including National Institute of Aging Merit Award, Scientist of the Year by the Alzheimer Drug Development Foundation, Goodis Prize of Excellence in Alzheimer Drug Discovery, 10 Best Minds by US News and World Report, and the US Presidential Citizen Medal from President Obama. So I really thank you, our speakers, for being today. I stop this first part and I leave it to Professor Genazzani to this lecture. Thank you very much.
Thank you very much, and thank you to everybody to be here. This is a new tradition, and that we have launched the new journal, GRAM, Gynecologic and Reproductive Endocrinology and Metabolism, which is an open access journal of the International Society of Gynecological Endocrinology. And we have decided not only to publish the beautiful paper, but also to present our author, to have a discussion, to introduce their investigation and their study. And this make the journal closer to the people, but this make also the author more open in mind, not only in mind, but also open in face and open in the possibility to explain better what they are doing, why they are doing, and what they will be the goal. And today we have a fantastic, charming scientist lady, which is also a member of the board of the International Society of Gynecological Endocrinology, Professor Roberta Diaz Brinton, who have made that beautiful paper that you can see here, you can download from the journal, Precision Hormone Therapy, Gaps and Opportunities. Please, Roberta, the microphone is yours.
Okay, great. Well, After that, I want to thank Dr. Genazzani and David Genazzani for the opportunity to give you an update on our thinking regarding precision hormone therapy. This is a work in progress, and we're very excited that we were able to publish our thoughts in the latest GREM issue. These are my disclosures, my sponsors, the patents that we hold, and the biotech that we've started. So this is a long journey, and this is the beginning of the journey for a path to precision hormone therapy. As many of you know in the audience as clinicians, the symptoms of the menopause are variable. What we have identified is that during the perimenopause, this transition state, there is a decline in glucose metabolism in the brain and a rise in the variability of outcomes in the brain. And that is exhibited as symptoms. As you know, 20% of women are asymptomatic, 80% of women are symptomatic. And here are a list of multiple symptoms that can occur during the perimenopause and menopausal transitions. What is a unifying feature here is that these are neurological transitions, and that has really laser focused our attention on trying to understand what occurs in the brain during the perimenopause and menopause. A major issue that is key in the field is who is appropriate for hormone therapy, when are they appropriate, and what hormone therapy. And what we have found in our research is it's complex. And that complexity is in part generated by two aging programs: chronological aging that precedes the transition, and the next program is endocrinological aging, which has its own components that I'll talk more about, and then followed by a second phase of chronological aging. And this is critical when considering when to introduce hormone therapy and the duration of hormone therapy. So this is the complexity that we have found in metabolic aging of the brain, where there's an initial, as I mentioned, decline in glucose metabolism in the brain that is evident during the perimenopause and increases over the postmenopause. And that there's also now a shift to utilizing auxiliary fuel to compensate for this decline in glucose metabolism. That is paralleled initially by an increase in amino acid metabolism that then rapidly declines. And throughout this process, there is a decline in mitochondrial oxidative phosphorylation, the ability to convert these fuels into ATP to fuel the energy demand of the brain. And then ultimately there is an increase in fatty acid metabolism in the brain. Again, part of this endocrinological aging process that has the potential to put the white matter at risk. In parallel to the metabolic changes, there are changes that are occurring in parallel in the immune system. Again, the decline in glucose metabolism, a rise in fatty acid metabolism. And what we initially see is this rise in the innate immune system, and then a switch to a rise and persistent activation of this adaptive, this reactive immune system that then in the postmenopause, both the innate and the adaptive immune systems are relatively high relative to the premenopausal levels. Now, this is, I think, important when we consider the increased incidence of autoimmune diseases that actually develop during the perimenopause and in the postmenopause. So these are a snapshot of the complexities that you as clinicians deal with on a daily basis. So what about menopausal hormone therapy? I think at this point, clinicians have done a superb job at personalizing the hormone therapy. And this is done in collaboration between you as the clinician and your patients. Where we are yet to achieve the goal is in precision hormone therapy, taking your personalized approach and now moving it beyond your specific interaction with your patient. And can we actually develop a precision hormone therapy approach, which is to be determined. So precision hormone therapy really is going to take into account the genetics of that individual, their current state of health and their history of disease, their age, their sexuality, their lifestyle, and then matching these components to specific, precise, and personalized hormone therapies. As you well know, hormone therapy is a whole body, multi-organ intervention that affects multiple organs. And in my talk today, I'll be speaking primarily about the brain. So what are the factors influencing hormone therapy? Well, these are ones that you know very well already: the dose and the interval of the treatment regimen, the formulation, the route of administration, and these clinical factors that I just mentioned. And you know very well that there are multiple, quite an extensive list of options of hormone therapy and routes of administration that you can utilize in your patient prescribing. And these are listed here in kind of general terms. Again, you're very familiar with these. When we looked at, and we published this in our GREM publication, that there are multiple estrogens, multiple dosage forms, multiple routes of administration, and again, dosing. And then there are individual progestin therapies listed here, and then combinations. Again, you're very familiar with all of these. The question really is which of these routes of administration, which of these formulations, which of these dosing strengths are actually appropriate for women that you see, and going forward for a larger population of women? How can we actually tell what is going to be optimized for that particular woman? So one of the questions that we asked in advancing this question about who and when, we asked the question, is it possible to identify women at risk for Alzheimer's disease when they're still healthy, before the disease has started? And this was published a number of years ago, work with Jamaica Repberg in my laboratory and colleagues. So the question really is who's at risk? We know that 11% of people over the age of 65 are at risk for developing Alzheimer's disease, and 2/3 of those people are going to be women. And so the question is who's at risk and who is not? So we conducted an analysis of the data from the ELITE trial, in which women had received estrogen therapy or placebo, and we looked primarily at the placebo group to try to understand what were the characteristics that we could detect using clinically deployable measures, indicators of metabolic health. And outcomes of that analysis initially showed, following a principal components analysis and K-clustering, that in fact, in this population of about 500 women, there were really 3 groups of women. One group was metabolically healthy and had the parameters shown there on the right. There was another group of women who were at risk for cardiovascular disease. Now, all of these women were within normal range. In this case, women had a slightly higher blood pressure, higher glucose hormone, and other indicators of potential metabolic dysregulation. And then there was a third group of women who were at risk for developing metabolic syndrome or type 2 diabetes. We then asked, in these women, what differentiated them on their cognitive function? And essentially what we found is that relative to healthy women, women with essentially a cardiovascular risk profile didn't perform as well, but not statistically different. It was the women who were in this third group, the poor metabolic health group, that showed significant decline in global cognition, verbal memory, and executive function. We then asked, who are the women that are driving this cognitive decline, significant cognitive decline? And it became apparent that it was the women who carried the Alzheimer's risk gene, the ApoE4 gene, that were driving this risk. So the combination of poor metabolic profile and ApoE4 led to a cognitive, an early sign of impending risk of developing Alzheimer's disease, cognitive deficits. It turned out, however, that the ApoE4 gene was equally distributed among this group. And what is exciting about this is that it really takes multiple factors to increase the risk of developing Alzheimer's disease. It's the combination of this risk gene and poor metabolic health that led to this decline in cognitive function. And I'll talk more about this later. But essentially, we know from decades of research that estrogen promotes metabolic health and sustains metabolic health in brain and in other organs. So then the question becomes, which hormone therapy is beneficial? And this is work done and currently being written up for publication by Dr. Eugene Kim, Greg Brannigan in my group, to really ask the question, is there a difference between hormone therapies and risk of developing neurodegenerative diseases of aging? This was a study conducted using a medical claims data set, the Humana data set, in which over 1 million women were identified who had received or not received menopausal hormone therapy. And after a number of meeting exclusion criteria, our ultimate population of study was around 190,000 women who had received hormone therapy and an equal number of women who had not. We then asked the question, what was the incidence of neurodegenerative diseases within 1 year from the index rate for receiving or not receiving hormone therapy? And what you see here is overall, all estrogen or hormone therapies combined, we see that there is, here's the risk of 1 and higher risk of 1.2. And what we see is that for all age-associated neurodegenerative diseases listed here, there was a remarkable decline in risk of developing any age-associated neurodegenerative diseases. You don't see the arrow bars here because they are small. But this held for Alzheimer's, Parkinson's, dementia, non-Alzheimer's dementia, multiple sclerosis, and ALS. The numbers for multiple sclerosis and ALS were much smaller. You see the numbers here, so the error, the variability was higher. But overall, hormone therapy in the aggregate reduced the risk of developing these age-associated neurodegenerative diseases. When we looked at different compounds, different formulations of estrogen and hormone therapy, we see that there, for example, there's a lot of variability in the estroderm and delestrogen, but overall, there's still a reduced risk of developing age-associated neurodegenerative diseases with all formulations containing estrogen. Again, looking at specifics here for each formulation that we studied, we see that for Alzheimer's disease, they are quite effective in reducing the risk of Alzheimer's disease, in Parkinson's, dementia, and then non-AD dementia. there were not sufficient numbers of people in the ALS group to do this analysis. But I think what's also interesting here is that when you look at multiple sclerosis, there's variability in the risk. And in fact, at some point, the variability, the statistical variance crosses 1 and extends beyond 1. So MS is a unique category. Overall, and for Alzheimer's, Parkinson's, and dementia, there is a reduced risk with these formulations. These formulations were selected because of the number of women receiving them, and what allowed us to conduct statistical analysis. When we looked at route of administration, whether it was oral or transdermal, again, we see that overall, there is a reduced risk of developing each of these diseases, whether it's oral or transdermal, although the transdermal data is less, there's fewer women in each of these groups. So this is an area that we really need to study more deeply with multiple data sets versus the oral, which has been used extensively for many years. Then we asked the question, excuse me, Dr. Kim asked the question, what about duration of treatment? And what we see for all of the neurodegenerative diseases combined, Alzheimer's, Parkinson's, and dementia, and non-AD dementia, we see that the longer the treatment, 6 years and longer, the greater the protection. This does not hold for MS because we did not have sufficient number of women in this category, but it was still protective in 3 to 6 years of exposure. And that's shown here. So 1 to 3 years, we see a 0.6 reduction or 0.4 reduction, 40% reduction in risk, a 60% reduction with 3 to 6 years, and 6 years and longer, the most profound reduction in risk for developing Alzheimer's disease as an example. These data are consistent with earlier findings in the field. They're not consistent with findings of population-based analyses that some have found no benefit or slight increased risk. But we have reproduced for Alzheimer's disease earlier studies and now have extended that across multiple age-associated neurodegenerative diseases. So again, this highlights the aspect of aging, right, and duration. And what we see is that the effect of hormone therapy is greatest this is for Alzheimer's disease, when the disease is typically diagnosed. The average age of diagnosis for Alzheimer's disease is 72. And so what we see is that the greatest benefit is actually in the oldest cohort, with finally where we know that increased risk of developing Alzheimer's disease in the 80s is quite large, and we see a profound reduction in that risk with a longer duration of therapy. So what about women who don't want to take a steroidal hormone therapy? Are there options? And one of the options that many women have elected to use is over-the-counter phytoestrogenic formulations. And we took a look at this because so many physicians asked us about what is the risk for their patients who are taking these over-the-counter soy extract products. And we did an analysis, some of that data I'll show you, the clinical outcome data I'll show you here, of a formulation that we developed for 2 reasons. One is, this is the phytoserms that target estrogen receptor beta. And the principal reason why women elect not to receive hormone therapy is fear of breast cancer. So in order to effectively target the brain, one had to consider the impact of therapy on the breast. So we developed an estrogen receptor beta formulation that targets estrogen receptor beta because estrogen receptor beta is associated with inhibition of proliferation in the breast, whereas our decades of research have shown that targeting estrogen receptor beta in brain has many of the same benefits of targeting both ER alpha and ER beta. And the publications that support that, the scientific research that support it, listed here. We conducted a phase 1b/2a clinical trial and for safety and feasibility of our phytoserm formulation in 70 peri and postmenopausal women who presented with vasomotor symptoms and subjective cognitive complaints. We had 2 doses of 50 milligrams and 100 milligrams once per day for 3 months. Our primary outcomes were safety and pharmacokinetics. We also conducted exploratory analyses on hot flush frequency and cognitive function. The outcomes of that trial showed that there were no indicators of toxicity, which was terrific. We had predictive pharmacokinetics. The effective dose is 50 milligrams. We do not need a higher dose of 100 milligrams. And we were able to detect a change in hot flash frequency, a change in cognitive function, and the potential of a biomarker of responders appears feasible. So looking at the responder analysis, we did a retrospective analysis of the phytoserms on 2 outcomes, hot flushes and a cognitive test that I'll talk about in a moment. And what we see over the 3 months is fairly typical in the placebo for these types of trials where women will cease to have hot flushes just spontaneously. In the 50 milligram dose of phytoserms, we were able to see a significant decline in hot flush frequency, and again, no benefit of a higher dose. We selected Trails B because of our work of understanding estrogen mechanisms of action in the brain and understanding that estrogen is required for complex tasks that require associative learning and learning across time. And that's fairly typical and has a temporal constraint. And that is Trails B meets those criteria. Trails B is a test where one has to toggle between a numeric set of numbers and a set of letters. So A, you had to go from 1A, 2B, 3C onward throughout the alphabet. And it's a timed test. And so a decline in score actually means a faster cognitive speed. And what we see is that with phytoserms, there is a faster rate of completion of Trails B relative to placebo. This was not statistically significant. Obviously, we require a larger N for this study going forward. In an attempt to try to understand who would be responders, Dr. Yvette Wang in our group conducted a number of analyses looking at mitochondrial haplogroups and whether the mitochondrial genetics would influence response to phytoserms. And here she looked at haplogroup H because we had sufficient number of women in that group, and all the other haplogroups were combined. And essentially what we see is that mitochondrial haplogroup does not really influence the change in hot flush frequency. That change in hot flush frequency occurred in both the haplogroup H and the non-H. What about Apoe genotype? And again, this is getting to attempting to bring precision medicine approach to this, looking at genetics, both mitochondrial genetics and nuclear genetics. And what we see here, we had sufficient number of women in the ApoE3 group, again, change in hot flush frequency. We see this also in ApoE4 carriers. There were not sufficient number of women who were ApoE4 carriers, which are typically about 14% of the population. So we don't really see a genotype, and we don't a nuclear genotype difference on Apoe genotype or on haplogroup. What about in Trails B? Again, what we see here, there were a few women in the haplogroup H. Again, what we see is the same pattern, maybe a little more evident in the haplogroup H, but overall, the same pattern as we saw in the aggregate. For change in better performance for Apoe genotype, again, we see that the ApoE3 carriers and the ApoE4 carriers are performing comparably. So for the phytoserms targeting estrogen receptor beta, there does not appear to be either a mitochondrial haplogroup impact or an Apoe genotype impact, which I think is pretty encouraging that this may in fact be more generalizable. What about women who are receiving anti-estrogen, hormone modulating therapies? This was work that was recently published by Greg Brannigan, an MD, PhD graduate student in my group, and asking the question, what is the impact of hormone modulating cancer therapies on risk of later life development of neurodegenerative diseases? I will tell you that I was surprised by the outcome. So again, we started out with about 320,000 women in the data set, medical claims data set, the Humana data set. Ultimately, the analyses were conducted on 18,000 women with hormone modulating therapy exposure for breast cancer and about 40,000 women without exposure. And what we see here is, here shown in red is tamoxifen, or these are the aromatase inhibitors, excuse me. This is raloxifene, and this is tamoxifen. And what we see is in the aromatase inhibitors, which were surprising to me, and tamoxifen, which was not surprising because we'd shown that tamoxifen actually is an estrogen agonist in brain, both reduce the risk of developing multiple age-associated neurodegenerative diseases. We did not see a significant effect or protective effect of raloxifene in this data set. So coming back to this surprising finding of the aromatase inhibitors was that we then looked at, well, what are these molecules? And what we found is that there's a steroidal aromatase inhibitor, exemestane, and the non-steroidal aromatase inhibitors, anastrozole and letrozole. And essentially, both were effective, although the steroidal aromatase inhibitor, exemestane, had greater benefit in reducing the incidence of all neurodegenerative diseases, Alzheimer's and dementia and non-AD dementia. So when we looked at the impact over time, this shows the survival curves, or the survival curves for reduced risk for patients receiving hormone modulating therapies. Here is the non-hormone and the hormone, and essentially there's no difference, oops. But the real difference comes again with age, with women experiencing greater benefit at the older ages of receiving these breast cancer therapies. Again, indicating that the intervention of these hormone modulating therapies, some of which can be estrogen receptor modulators, and we're now doing analyses. Greg is continuing his doctoral research in this area to understand their mechanisms of action for both the aromatase inhibitors and for tamoxifen and raloxifene. So this gives you a profile of the studies that we can do that go from the bench to large data sets. And to summarize then, the path to precision hormone therapy to prevent and delay neurodegenerative diseases really build on what clinicians have already achieved, which is a personalized hormone therapy approach. And moving that personalized hormone therapy approach to precision hormone therapy, can we actually identify what the responder group in those larger population studies, can we actually identify those women? Who are they? When are they treated? What are they treated with? And this is really going to require much larger data sets, which we are now in the process of analyzing. Taking our earlier observations, replicating those, and trying to define which of the hormone therapies are most beneficial. And going forward, though, we still won't have a good idea of the precision component of that, because we'll need genetics, we'll need those electronic medical records. And we're hoping we can actually achieve this through other data sets that are currently available here in the US and in the UK. So going forward, this will be our strategy of, again, trying to identify those women who are at greater risk for developing age-associated neurodegenerative diseases, and formulations and dosing and routes of administration that optimize the reduction in risk. And ultimately, it should be possible to create a decision-making algorithm based on the medical data that that patient presents to you when they come into your clinic, and ultimately the prescription of a hormone therapy. So with that, I will thank you and take questions, and let you know that I hope to see you at ISGE in December. Thank you.
Thank you. Thank you, Roberta. First of all, I invite everybody to send their question using the question and answer. You can write your question. We have received some of them. First of all, I would like to thank you also because you have presented some new data and some fantastic and interesting data on the fact that aromatase inhibitor and anti-estrogen, they, at least those data on tamoxifen and raloxifen and aromatase inhibitor, that they have no negative impact. You remember that we had a lot of concern as estrogen are a so important partner for the brain cells, either the neuron as well as the glia cells. The aromatase inhibitor, we were afraid that this can touch this positive impact. But now going to the question, okay, we have one anonymous participant who have made a question. Are there data now to advance precision hormone therapy?
Yes, and so yes, and is that data available? Oftentimes, no. The data really comes from you, the clinicians. I have to say, being in collaboration and interaction with clinicians has really transformed my research direction to really ask these clinically meaningful questions and try to understand how these molecules are exerting their effects. So the answer is yes, there are data available, like the ones that I showed you, like the ones that have been published already, like the data that's been published already from epidemiological population studies. What does not yet exist, but which is in your hands, is the medical record, your analysis of that patient. And so that's really the key to moving from your personalized approach to the precision medicine approach, to combine the two so that it's both personalized and precise. To get back to your earlier point, Andrea, is that something that really surprised me about the aromatase inhibitors was that they were beneficial. And we don't know why. Where our hypothesis, though, is that the aromatase inhibitors, particularly the steroidal one, exemestane, actually is binding to estrogen receptors. That's our hypothesis, and that's what we're pursuing. I would have like you and others, was very concerned because when women learn that the research that I do on estrogen and hormone therapy, they'll often, many women will share with me their cognitive complaints. And then when I ask them what breast cancer therapy they're on, invariably it's an aromatase inhibitor. So I was very surprised to see this. And again, coming back to this precision approach, which of these women are going to, why and which of these women are going to respond favorably and have the benefit of an estrogen agonist by these compounds in the brain versus those who will not?
Thank you, thank you. No, also, this was a fact that your data are changing the perception that we had, but we had only perception. And we have also received a question from Mirella Paracchini. She asked a general question on the world of menopause hormone therapy. There is no limit in the duration of hormone replacement therapy from your data?
Yeah, so essentially, when we looked at duration of exposure, 6 years, we looked at 1 to 3, 3 to 6, and 6 and longer. I want to say for some women, they were on hormone therapy for 20 years. So again, let me back up to a very early slide that I showed around the chronological aging versus the endocrinological aging. And what estrogen therapy or hormone therapy does is delay the impact of endocrinological aging. Now, why is that important? Because the health of the female, the woman that comes in early on during her perimenopause, if you will, her health at that point, chronological aging, determines kind of the endocrinological aging phenotype, the severity, the type of symptoms. And then it's the early chronological phase 1 chronological aging plus endocrinological aging then equals the second phase of chronological aging, whether that's successful aging or whether it's very vulnerable aging. And so what estrogen therapy does is mitigate some of that chronological aging. And that's why it's so important to target women early on with hormone intervention before that chronological aging is out of control. Early intervention is far better than later intervention because estrogen doesn't roll back the clock, it extends the clock.
And we have also from Manju Navani a question. You were speaking about hormone therapy. She asked, is there a difference in benefit between estrogen only and estrogen plus progestogens? And I would like to go even more in deep. Progestogen is a family. Progesterone is another natural hormone. I would like to have your view on that point.
So in our in our discovery science at the bench, what we found is that estrogen plus continuous combined progesterone is comparable to an ovex brain phenotype. So estrogen plus progesterone combined continuous exposure we did not see in the brain that it was beneficial. It actually had the profile as if there were no hormones there, which somewhat makes sense because of the antagonism of progesterone antagonizing some of estrogen's actions. On the other hand, if we used cyclical estrogen, then progesterone, we saw the best benefits in the brain. And one of the important aspects to talk about here, and this is work that we did in collaboration with Dr. Regine Citric-Ware, was that looking at different progestins, and their ability to mimic the action of progesterone in the brain. Progesterone in the brain can promote neurogenesis. Now, it may do that through its metabolite allopregnenolone. Allopregnenolone promotes neurogenesis. Progesterone actually promotes neurogenesis through a different pathway than the allopregnenolone. So progesterone alone can promote neurogenesis. When we looked at, for example, medroxyprogesterone acetate, what we found is that the brain responded to medroxyprogesterone the same way as the uterus did. Medroxyprogesterone acetate, even though it was given to prevent the proliferative effect of estrogen in the uterus, medroxyprogesterone acetate actually accelerates proliferation in the uterus. And what its mechanism of action is it counts on that all of those rapidly generated cells will have misreads in their DNA so that they'll be caught by the checkpoints in the cell cycle and then be removed. But that's a tremendous reliance on an aging uterine response to actually pull out all of those DNA damaged cells. Yes. And the same thing happens in the brain, that medroxyprogesterone acetate increases proliferation of neural stem cells dramatically. And again, it's depending on the catching of that DNA damage. And when you think about the breast cancer risk, that's likely also the reason why there's an increased risk of breast cancer in persons taking medroxyprogesterone acetate because of this hyperproliferation and reliance on the cell cycle checkpoints to essentially destroy the abnormal cells. So coming back, essentially, when we looked at the data in this Humana data set, in this insurance claims data set, estrogen plus prometrium was quite effective. And then when we looked at the usual prescribing of prometrium, it's that 12-day cycle of prometrium, essentially replicating the normal menstrual cycle. So,
then go back to the physiology, and the physiology represent probably for our genes also the better equilibrium existing between the two estrogen and progesterone compounds.
Yeah, so when we look at the transcriptional profiles in response to estrogen, so coming back to kind of estrogen regulation of metabolism, the regulation of metabolism is really regulation promoting glucose metabolism. This is particularly evident in the brain, but it's also evident in the periphery. And that the loss of estrogen in the brain reduces glucose metabolism by about 20 to 25% in the brain. And that activates a starvation response. And that starvation response is to utilize auxiliary fuels, and in this case, ketone bodies, to generate acetyl-CoA that can then go through the oxidative phosphorylation to generate ATP. Now, that's fine in the short term. It is not good in the long term because the brain is the most lipidated organ of the body. 2/3 of brain weight is lipid weight. And ultimately what we've found both in our discovery science and then in our clinical science, that the loss of white matter is likely through the catabolism of white matter as a source, a lipid source for ketone bodies. So that's very important to sustain the utilization of glucose in the brain as its primary fuel, which is what estrogen does.
We have one of our friends Roberto Cosimo Melcangi.
Ah.
Hi, Robbie. About the unexpected effect of aromatase inhibitor, what about a shift of testosterone into androgen metabolites?
You know, I have no idea, Roberto. Clearly, we need to collaborate on this. Yeah, I have no idea. I have not studied the androgens at all, but you're absolutely right. This is key. And what's happening if you have aromatase inhibitors? What's happening with, is there an increase in androgens in the brain?
And we have also another question. You have mentioned your data on phytoserm, and the question is, what are the substances? What kind of phytoserm you have used in that study?
Yeah, so we combined we did an analysis of about 500 different phytoestrogens. And this was a computational analysis of phytoestrogens that would bind to estrogen receptor beta, preferentially bind to estrogen receptor beta. From that computational analysis in silico computational chemistry, we then narrowed it down to about 40 molecules and then tested about 30 of those molecules at the bench. And the outcome of that analysis was a combination of Genazzani, Daidzyne, and S-equal. No one of them actually was particularly effective on their own. They all are very weak estrogens, but in combination, we were able to show that these are effective as an estrogen beta receptor agonist. And the concentration is critical. So that's part one, and the combination is critical. When we did multiple combinations, we tested multiple combinations, and this was the combination that was effective. And so then the question becomes, now you're giving 3, although, you know, that's not a lot compared to a soy extract, which is why we did the safety trial and found that there were no adverse effects. So one of the things, though, I want to mention is that these over-the-counter drugs or phytoestrogen formulations are not tested. They're assumed to be safe. And in our studies, what we found is that a product, and we published on this, the Johnson & Johnson product titled Healthy Woman, actually induced a phenotype worse than having the ovaries removed. So it wasn't effective and it wasn't safe.
And we have one of our board members, which is also a very famous neuroendocrinologist who give his regards, is Fred Naftolin.
Ah, hello, Fred.
He have make a question about, I'd like to have your comment on the effect of the time of starting the menopausal hormone therapy. If one intercepts your proposed changes, it has immunity, one would expect that the age or the time of starting treatment related to the menopause to be important. This would also fit in well with the findings regarding cardiovascular risk.
Yeah, so again, you know, estrogen does not roll back a situation, it prevents a situation from developing. So, and it extends kind of this health span for women. And so, you know, as you, Fred, and Andrea and Tommaso have all recognized, is that the time to start hormone therapy is certainly at the time when symptoms occur. What I will tell you is that our research has shown that the immune system is actually the Kickstarter to this perimenopausal transition. We see a rise in immune signaling prior to any change in cyclicity, suggesting the possibility of, at the very least, immune intervention, but whether, you know, a hormone intervention is also feasible. And you think about the women who, and which is another fascinating group to study, women who were put on oral contraceptives to regulate their cyclicity during this early phase when irregular cyclicity begins, and whether that has a benefit. We have some evidence to suggest that oral contraceptives have benefit on neurological outcomes. This is work with Roxana Karim and Wendy Mack at USC. Clearly more research needs to be done. And that's where the larger data sets, and this is something we can answer in the medical claims data set, because we know the age of the woman who's starting the oral contraceptives, and really looking at what's the impact long-term on that intervention.
We have also still from Fred an interesting question. Could you relate your findings of the time phase of aging to the problem of the response during COVID-19? You know, women, they have a particular apparent protection in COVID-19 complication development in comparison to men, at least here in Europe. In Italy, you know, in Italy we had 14.4% of death, 14.4. You in the United States, you are at 5 point something. We had 14.4. And the ratio between women and men was absolutely dramatically in favor of women. And then we have more men dying of advanced age. Did you believe that what happened in the immune control around the menopause can have some impact on that point?
So I think a stronger impact is the increased smoking in men, which put their lungs at risk, the increase in hypertension in men, which has a known sex difference in men. So I think there are other more reasonable or more plausible explanations for the male, the increased hazard risk in males, some of which is genetic, if they're prone to hypertension. In the US, we see that persons of African origin, Black American men are at greater risk. And we know that they have greater risk for hypertension as well. So, but where I think that's really exciting is, the potential to now use these antihypertensive agents as potential interventions very early on in these vulnerable populations in men, whether they do have a hypertensive condition. What I would say also is that there was an idea floated of treating men with estrogen, and I really think that's a bad idea. I don't think that's a plausible strategy to explain the sex difference.
We have another interesting question from Sergio Brantes. He gives his regards to you. He asks you, you showed a possible relationship between age, glucose metabolism, ketone metabolism, and dementia, all of which are closely related to metabolic syndrome. The question is, do you think improving ketone metabolism could be a modifiable factor that could protect the brain in any way?
So it depends, right? So I think prior to the utilization, so again, let me just roll this back. So there are these adaptive responses that occur. So if the brain is now dependent on ketone bodies, then the question becomes, are they using their white matter as a source of those ketone bodies? So part of what we really want to do in this situation is not so much increase the utilization capacity for ketone bodies, because if they're using white matter, that's simply going to potentially increase the catabolism of that white matter. I think that a different approach is, how can we actually bring that brain back to being dependent on glucose as its primary fuel, and protect the white matter? And I don't have an answer to that question. Obviously, prevention of type 2 diabetes is critical. Maintaining glucose homeostasis in persons with type 2 diabetes is critical. Can we roll that system back? And why I'm hesitant is because when we look at the transcriptome of the brain during this transition to utilizing ketone bodies, there are, the perimenopause is a transition state. It's going from one metabolic system to now bringing on another metabolic system. It's not that the glucose system is no longer in play, it's that it's lost the estrogenic control. So then the question becomes, how can we restore that? Right? We can prevent that loss of estrogenic control and sustain glucose metabolism in the brain by early intervention with estrogen therapy.
Yes, yes.
Then the question becomes, can we roll that back? And I don't have an answer to that question, but I think it's a very important one.
It is. Then we have one still on the precision hormone therapy. It's also from an anonymous. Is the hormone therapy generated in compounding pharmacies achieving precision hormone therapy? Because you know, this the compounding pharmacies is a large problem everywhere in the world.
Oh, well, I would say that the goal, I think the clinical goal for use of compounding pharmacies is to personalize that hormone therapy. And so it is a laudable goal, absolutely. The problem with compounding pharmacies is that they're not regulated. They're certainly not regulated here in the US. So you don't know where they're securing that, what's their pipeline for steroids, where is it coming from, what's the quality control, and that's not to say that there isn't quality control, it's just to say that it's not regulated. And then and I'm sure you all have heard this too, I've been shocked at the amount of estrogen and androgens that oftentimes are included in these formulations that they make, and that there's no kind of counseling to the patient that, gee, if you start to see these androgenic effects, that means you need to use less. So I think, my preference is to utilize the products that are regulated for both quality and quantity and sourcing of steroids. Where I think the field needs to grow is in providing options for physicians. Physicians are going to compound pharmacies because of the options that are available. So how do we actually increase the option that will allow us to take a highly regulated, well-documented therapeutic and couple that with the personalized approach that clinicians are trying to achieve?
Thank you very much. We are already at 7:07, and we have take also more time. We have 51 other questions inside. I would like to thank all of those who have put the question. We will send the question to Roberta. I would like to tell you, you can follow again this fantastic webinar when it will be freely available in the webcast. And I think it's a great opportunity. Roberta, thank you very much for the beautiful data that you have shared with us, and for the beautiful brain. The female brain is really, I think we have a gender difference, the male brain and the female brain, but the female brain have that fantastic vision on the world, on the possibility to take care. And you were taking care of us today with that beautiful lecture. I thank you very much.
See you in December. Stay well.
In December in Firenze. I remind you, we will be From the 2 to the 5th of December, we will be in Firenze for the Congress of Gynecological Endocrinology. You will follow her. She has 3 fantastic lectures, different from that one, and we can discuss about these points. Dear friends, thank you very much. We will be, this is the journal of Gynecological and Reproductive Endocrinology and Metabolism. It's an open access journal. You can go on it. We would like to ask you to submit your papers and to read our papers and to follow our authors. In August, we will have another session with Professor Antonio Cano, who will speak about of ibandronate and raloxifene effect in postmenopausal osteoporosis. You will enjoy. Then thank you again, Roberta. Thank all of you. And okay, I wait you next time in August to follow another of our authors. Thank you very much.
Bye. Stay well.
Stay well. Take care.